Okay, thank you very much. So I have got 20 minutes to sum up all gynecology. I want to emphasize that the basis of all ultrasound diagnosis in gynecology is grayscale ultrasound imaging. Learn to master grayscale ultrasound imaging before you start using Doppler. And if you want to use Doppler, you must be familiar with Doppler physics, you must understand the pitfalls of Doppler ultrasound, you must be able to recognize Doppler artifacts and distinguish them from Doppler signals that emanate from blood vessels. And your Doppler settings must be correct, and usually a velocity scale of 3 to 6 centimeters per second is optimal. Common myometrial pathology is myoma and adenomyosis. These are the typical ultrasound images of a uterine myoma. Uterine myomas are round, oval, or lobulated solid tumors casting stripy shadows. However, some myomas are hyperechogenic, as you can see here, and some contain cystic areas because they have undergone degeneration. But the vast majority of myomas are round, oval, or lobulated solid tumors casting stripy shadows. Relatively common myometrial pathology is adenomyosis. There are 4 typical ultrasound features of adenomyosis: an enlarged uterus, either asymmetrically enlarged or globally enlarged, fan-shaped shadowing, cysts in the myometrium, and a poorly defined endometrial myometrial border. So these are ultrasound images of an enlarged uterus. This is a sagittal section through the uterus. This is the endometrium, and you can see that the anterior wall of the uterus is thicker than the posterior wall. It is an asymmetrically enlarged uterus, and this is a globally enlarged uterus. These images also illustrate fan-shaped shadowing, stripes of shadows, and this sign is also called the rain in the forest sign. Cyst in the myometrium is a very specific sign of adenomyosis, and this image here illustrates poorly defined endometrium. You can really see the endometrium growing into the myometrium here. The most common intracavitary pathology is polyps and submucous myomas. There are 4 typical ultrasound features of an endometrial polyp: bright edge, hyperechogenic endometrium, regular cysts, and a feeding vessel. The bright edge is white lines that surround either the whole lesion or parts of the lesion. Most polyps are hyperechogenic, and in postmenopausal women, polyps often contain regular cysts. And if you switch on the color Doppler function of your ultrasound machine, you might see a so-called feeding vessel, one large vessel seen to penetrate into the endometrial echo from the surrounding myometrium. These are typical ultrasound images of a submucous myoma. A submucous myoma is a solid tumor protruding into the uterine cavity from the surrounding myometrium and having the same echogenicity as the surrounding myometrium. And if you switch on the color Doppler function of your ultrasound machine, you might see a ring of color surrounding the submucous myoma. It is very common to find cystic lesions in the adnexae, both in asymptomatic and symptomatic women, and both before and after menopause. If you find a cyst with one cyst locule, smooth walls, and anechoic cyst contents, no larger than 3 to 4 millimeters in a woman of fertile age, it is almost certainly a functional cyst that will regress spontaneously. Even though we cannot suggest a specific histopathological diagnosis, when we see a cyst with one cyst locule, smooth walls, and anechoic cyst contents, the risk that such a cyst is malignant is minimal, at least if the cyst is smaller than 10 centimeters in diameter. It is very important to be able to recognize the typical ultrasound image of a hemorrhagic corpus luteum cyst. The most typical feature is this one. The hemorrhagic corpus luteum cyst has spider web-like contents, but may also contain blood clots. Hemorrhagic corpus luteum cysts regress spontaneously. Dermoid cysts and endometriomas are common findings in the adnexae, both in asymptomatic and symptomatic women. These are the typical ultrasound features of a dermoid cyst. The most typical feature is this one. You have a round white ball filling part or the whole of the cyst. This white ball consists of hair and sebum. A second typical ultrasound image of a dermoid cyst is this one. You have thick, bright white lines and thick, bright white spots corresponding to hair swimming in fluid. And a third typical ultrasound finding in a dermoid cyst is the presence of shadowing, which is explained by the ultrasound beams being absorbed in the ball of hair and sebum or being reflected by bone, cartilage, or teeth. These are typical ultrasound images of endometriomas, a unilocular cyst, a cyst with one cyst locule, thick walls, and containing homogeneously ecogenic material corresponding to the chocolate sauce-like contents in an endometrioma. Many endometriomas contain wall nodularities, protrusions from the cyst wall into the cyst lumen. These protrusions probably consist of blood clots or fibrin, and they should not be confused with papillary projections, which are a sign of malignancy, and I will come back to that later. Now, unless you work in a very specialized ultrasound center to which is referred only women with very strange adnexal masses, and unless you work in an oncological center, I can assure you that at least 45% of all adnexal masses that you will see in your practice will fall into one of these four categories. For the remaining adnexal masses, the following rules of thumb apply. Any irregularity, be it in the contour or in the internal echogenicity of the tumor, classifies the mass as malignant, and the absence of irregularity classifies it as benign. There is only one exception to this rule, and that is that some very large multicystic tumors with an innumerable number of cyst locules are mucinous borderline tumors of the gastrointestinal type. So now I have described some common pathologies in the uterus and in the adnexa. So how do we describe our ultrasound findings to our colleagues or in an ultrasound report? We should use standardized terms, definitions, and measurements. Why do we need standardized terms, definitions, and measurements? We need standardized terms, definitions, and measurements to understand each other in our daily clinical practice. If I say papillary projection, it should mean the same to you as it means to me. If I say multilocular solid mass, it should mean the same to you as it means to me. If I report the size of a papillary projection, it should mean the same to you as it means to me. That is, everybody should take their measurements in the same manner. Of course, it is necessary to use standardized terminology for it to be meaningful to join the results of scientific studies into a meta-analysis or to compare the results of different scientific studies. And of course, if we want to perform multi-center studies, the same terminology and the same measurement technique must be used in all centers. Now, there are 3 published consensus statements on which terminology we should use. One consensus statement, the IOTA statement, on which terminology we should use to describe adnexal masses. The IETA consensus statement on how we should describe our ultrasound findings of the endometrium, and the MUSA consensus statement on how we should describe our ultrasound images of the myometrium. And I would recommend you to read these consensus statements because it is impossible in a 20-minute lecture to go through all the details of these consensus statements. These are the variables that we use to describe ultrasound images of adnexal masses. 4 of these variables are particularly important, and therefore I would like to go through the definitions of these terms with you. Solid component, papillary projection, type of tumor, and color score. When we use IOTA terminology, the definition of a solid component is a structure that has echogenicity suggestive of tissue, such as myometrium or ovarian stroma, and all tissue is potentially vascularized. This means that the white ball in a dermoid cyst is not a solid component. A ball of hair and sebum cannot be vascularized. A blood clot or a lump of mucus is also not a solid component because a blood clot or a lump of mucus cannot be vascularized. The IOTA definition of a papillary projection is protrusion of solid tissue into a cyst cavity with a height of at least 3 millimeters. So when we use the IOTA terminology, protrusions with a height of less than 3 millimeters are not classified as papillary projections, but only as wall irregularities. But of course, a papillary projection is a solid component. It consists of tissue that is potentially vascularized. This is not a papillary projection because this solid component doesn't protrude into the cyst cavity. When we use the IOTA terminology, there are 5 types of tumor, and this is extremely important. A unilocular cyst is a cyst with one cyst locule, no septa, and no solid components. A unilocular solid tumor is a cyst with one cyst locule and 1 or more solid components, and the solid component can be a papillary projection or some other type of solid component. A multilocular cyst is a cyst that contains septa but no solid components, and when we use IOTA terminology, a bilocular cyst is a multilocular cyst. A multilocular solid tumor is a cyst that contains both septa and solid components, and the solid components can be a papillary projection or some other type of solid component. And a solid tumor consists of at least 80% solid tissue. The IOTA color score is based on subjective evaluation of the color content of the tumor scan and is rated as a color score of 1, 2, 3, or 4. A color score of 1 means that no color Doppler signals are detectable in the adnexal mass. A color score of 2, that a minimal amount is detectable. A color score of 3, that a moderate amount is detectable. And a color score of 4, that abundant color is detectable. Of course, when you estimate the color content of your tumor scan, you must know how to adjust your settings to maximize detection of low velocity blood flow without artifacts. And as I've already said, usually a velocity scale of 3 to 6 centimeters per second is optimal. Then you increase the Doppler gain until you see artifacts, and then you decrease it until you see the artifacts just disappear. Now, the IETA consensus statement describes which terminology we should use when we describe our ultrasound images of the endometrium and the uterine cavity. And I will discuss with you only one definition that I think is particularly important, and that is the definition of a focal lesion. A focal lesion in the uterine cavity is anything that protrudes into a fluid-filled uterine cavity above the endometrial baseline. So a focal lesion can be a polypoid lesion, it can be an area of thickened endometrium, or it can be just small blips protruding above the endometrial surface. For the MUSA consensus statement, I have to refer you to the consensus statement because there is no time to go through this consensus statement in detail. So to sum up, common uterine pathology that manifests typical ultrasound appearance is myoma, including submucous myoma, adenomyosis, and polyps. Common cystic structures in the adnexae with typical ultrasound appearance are functional cysts, including the hemorrhagic corpus luteum cyst, and simple cysts, dermoid cysts, and endometriomas. And for other adnexal lesions, the following rules of thumb apply. Any irregularity classifies the mass as malignant. And we should use a standardized terminology when we describe ultrasound images of adnexal lesions, the IOTA consensus statement, of the uterine cavity, the AITA consensus statement, and of the myometrium, the MUSA consensus statement. Thank you very much for your attention.
Thank you very much, Professor Valentine. Perfect timing as usual. Any question from the audience? There is a question online from the center of Alexandria, Egypt. They're asking about the significance of the sliding and mobility of the structures during transvaginal examination and if they can predict adhesions.
Yes, as I mentioned earlier this morning, the beauty of vaginal ultrasound is that we can assess mobility, and if when we push upon the organs with the vaginal probe or with our free hand, if the organs don't slide, this is a sign of adhesions. Yeah, so it's definitely possible and important to do it.
Okay, I think there is a question from the audience.
Just a clarification of the definition of polyps that can or cannot with cyst. When we visualize them, how can we say it's primarily a cyst or a polyps, and where it starts and where it ends?
I'm not sure. Do you mean what polyps look like on ultrasound? Or what is...
Because on the 4 characteristics of a polyps
Yes.
on the slide, the last one might be with cyst.
Yeah.
And that one,
Yeah.
I can only see the cyst, not the polyp. So that was my question.
So, for example, what you see here, this is a sagittal section through the uterus. This is the endometrium. You can see a white line here and a white line here. This is the so-called bright edge, which reflects the interface between the polyp and the endometrium. And inside this polyp here are regular small cysts, at least one relatively large smooth-walled anechoic cyst. This is a very typical finding of an atrophic polyp in a postmenopausal woman. So here, for example, you have a hyperechogenic polyp. You can see the bright edge, which reflects the interface between the polyp and the endometrium.
I think we can have a last question from the online satellite courses. A question from Brazil: is there any limit for wall asymmetry for adenomyosis?
No, it's completely based on your subjective evaluation, actually.